I'll preface this video with an apology for my nasal enunciation. I'm coming down with a cold, so I do apologise. But despite that, I felt this video was important enough as a rebuttal to something that I saw yesterday in regards to COVID-19. Now, I thought we were done with COVID-19 conspiracy theories, and there is still a lot to unpack about COVID-19. Make no mistake, there is still a lot of uncertainty surrounding the whole scenario, from governmental preparation to origins of the virus and everything in between. But there are some things that are just undeniable fact, supported by evidence. And I find it quite offensive when people come out with videos claiming that what they are telling you is fact-based when they provide no evidence to back it up. And it's in these moments where silence becomes unhelpful. Not because disagreement is uncomfortable, but because misinformation causes real harm. Now, as I mentioned, there was a video circulated recently featuring David Icke in which he makes a series of claims about COVID-19, care homes, end-of-life medication, and healthcare professionals in general. And these claims are presented as documented fact. As someone who's worked in infection prevention and control for over 20 years, I do want to make something clear from the outset. Disagreement is healthy, scrutiny matters, but factual accuracy matters more. So today, we're going to slow things right down and look carefully, claim by claim, at what is being said and what the evidence actually shows, not to attack the person, but to protect truth, staff integrity, and the public's understanding of medicine. Now, the first claim was there was no real infectious agent. COVID-19 was an illusion created to frighten people into complacence. This is what is being claimed from his transcript. You didn't have a real infectious agent. They had to create the illusion of a deadly virus. Now, the factual reality is that SARS-CoV-2 is a well-characterized virus, isolated, sequenced, replicated, independently verified across hundreds of labs worldwide via electron microscopy, tracked epidemiology, and consistent transmission patterns. This isn't theoretical. This is standard virology. And COVID-19 outbreaks followed classic infectious disease dynamics: clustering, super spreading, incubation periods, healthcare-associated transmission, PPE-mediated risk. That's all commonplace. And as an IPC professional, you know this pattern immediately because it behaves exactly like a respiratory pathogen. If there were no real infectious agent, PPE wouldn't have reduced transmission, isolation wouldn't have worked, staff sickness patterns wouldn't have clustered, care home outbreaks would not have followed contact networks. Yet they did, consistently, across countries with no shared political control. Claim number 2. Hospitals were incentivized to fake COVID diagnoses and death certificates. Now, what's being claimed by David Icke is, why would you have to fake the tests, fake the death certificates, give financial incentives to hospitals to diagnose COVID-19? The factual reality is, in the UK, death certification follows a legal medical standard. COVID-19 could be listed as the cause of death, contributing factor, or incidental finding. And this distinction matters and was audited. There was no mechanism for individual clinicians or hospitals to profit from falsely certifying COVID-19 deaths. What did exist was emergency funding mechanism to expand ICU capacity, surge wards, cover PPE costs, and maintain service continuity. That funding was activity-based, not diagnosis-based. And importantly, clinicians do not receive bonuses for death certification. False certification is a criminal offence. There's no evidence ever emerged of falsification on the scale that he alleges. Now, this claim misunderstands both how healthcare funding works and how death certification is governed. His third claim was that midazolam was used to deliberately kill elderly patients. And this is a serious allegation that he's made. Now, what is being claimed is that old people were put on end-of-life protocols, given midazolam and morphine, levels that were bound to kill them. The clinical reality, midazolam is a benzodiazepine. It's used for anxiety, terminal agitation, dyspnea, palliative sedation, and for a few other anaesthetic procedures where clinically indicated. It's not a lethal drug when used appropriately. In end-of-life care, the underlying disease often causes death. Medication alleviates suffering. The dosages are titrated, and decisions are documented, reviewed, and multidisciplinary. Midazolam does not cause kidney failure, doesn't fill your lungs with water, doesn't create viral pneumonia. Respiratory depression is a known risk at excessive doses, which is why prescribing is cautious. But the suggestion that thousands of clinicians knowingly administered fatal doses to patients as part of a coordinated effort is incompatible with clinical governance, ethics, whistleblowing, and the absence of any evidence. Now, his fourth claim is remdesivir caused organ failure and was used to fabricate COVID deaths. He says that remdesivir caused kidney failure, they imposed it anyway, and that's what killed people. Now, the evidence base: remdesivir was trialled early during the early stages of the pandemic, showed modest benefit in some hospitalised patients, and was later de-emphasised as the evidence evolved. But importantly, acute kidney injury is common in viral illnesses. COVID-19 itself causes multi-organ dysfunction. Correlation is not causation. This is a classic reverse causality error. Very sick patients receive a drug. Very sick patients have organ failure. The drug therefore caused it instead of the disease. That's not medicine. That's misinterpretation. His fifth claim was that DNARs were applied indiscriminately. And what's true and important is there were serious concerns early in the pandemic about inappropriate DNAR application, especially in care homes. They were investigated, publicly acknowledged, formally corrected, and subject to safeguarding reviews. That matters. But acknowledging errors under pressure is not the same as alleged deliberate killing, murder. The NHS response included national guidance, individualised decision mandates, safeguarding escalation, and apologies where standards were breached. And this is what accountability can look like, not cover-up. Now, why these claims spread without any judgment is because these narratives resonate with people. They resonate because the pandemic was frightening. People saw loved ones deteriorate quickly. Myself and my wife did. Communication was far from perfect. Healthcare systems were visibly strained. Trust was shaken. In that environment, explanations that frame suffering as intentional can feel psychologically easy to accept than uncertainty, imperfect decisions, and human limitations. But emotional resistance is not evidence. And what this means for healthcare workers is claims like this do real harm. They undermine trust in clinicians and nurses. They re-traumatise families. They demonise people who act in good faith, and they erode public confidence in future outbreak response. Most healthcare workers did not feel powerful during COVID. Take my word for it. They were afraid, under-resourced, overexposed, morally burdened. And the idea that they were part of a coordinated killing programme is not only just false, it's offensive and profoundly unjust. It is right to question power. Of course it is. It's right to scrutinise decisions. It's absolutely right to learn from mistakes. What's not right is to rewrite medicine into malevolence without evidence. Because truth matters when fear is high. And clarity calmly delivered is not compliance. It's care. Thank you for listening. And as always, be kind, be curious, and always try and look carefully at what's hiding in plain sight. I will end this video as I have during the pandemic when there was multiple conversations taking place. Pandemic was one of the reasons I left the main aspects of social media, like the Facebooks and the Twitters and things. There will be people who will undoubtedly challenge this. And all I say, as all I've ever said is, that's fine, show me the evidence. Don't tell me that you know someone who has the evidence. Don't show me someone who is not a medical professional who has come up with evidence. I need to see the evidence, because people challenge and say, well, the evidence that you've got, the references for this, by the way, are available on my Substack article that goes into a little bit more detail, and all the references are there that I've used to inform this, as well as my own experience. And people will say the references that you use are forged by the government. All I can say to that is that that evidence is all the evidence that we've got. All the evidence we use in healthcare is provided by someone else. You have to take it on board, compare it to all the other evidence, and then eventually evidence does change. EPIC guidelines that we use in infection control are on their fourth iteration, because as time goes by, things evolve and change. That's the way evidence-based medicine works, evidence-based practice works. But at the time, that is the evidence that we have. Someone can't just say it's wrong. Well, they can. They can say, of course they can say it's wrong. And that they know for a fact it is, but not provide evidence. And to date, people that I've challenged about COVID have never provided me evidence to support their claims. They tell me I'm wrong. They tell me there's evidence. They tell me that their friend Stuart saw evidence. No one's ever provided me with the evidence. Provide me with the evidence to prove anything that I have said. Anything that I have said, important distinction, is incorrect. And I will be waiting. Look after yourselves. Bye.